Well, good morning everyone. It's a pleasure to be here, and we welcome you at this early hour for some. Introducing the Patient Journey 3 today, this morning to you, gives us the privilege of discussing with a group of highly recognized clinical and scientific experts to really go into the details when it comes to treatment planning and treatment execution for our patients today and going forward in the future. I think we've taken some efforts to put together a very interesting program for you, and I think with my co-moderator Eric, we will guide you through this. The intention for all the requests for all speakers was that we really provide useful information, things that you can use on Monday morning when you go back to your practice, and I think I'm quite confident that we will achieve this.
Yes, thank you, Stefan, and good morning, everybody. Thanks to be here this morning. I hope you had a nice party yesterday night. So this morning it's missing multiple posterior teeth, upper and lower, and I hope you will have a nice message at the end. At least we tried and we worked a lot on that. And we really asked our brilliant lecturers to be humble and really to stick to their topic. And of course, one topic besides the other, at the end you should have a complete message. So at the end of the 8 lectures, I hope the global message of missing multiple teeth would be quite clear to you. Do we have to rebuild bone? Do we have to use short implants? How many implants? What pre-implant examinations do we have to do, and so on. I think everything will be quite clear for you. So I think it's time now to introduce our first lecturer, Pierre Grandmont.
Right, and going into the treatment workflow that we have already experienced, or you have experienced in basically all lectures in the last couple of days, I think it is the fundamental requisite for our treatment today to know the basics, to know, do we need to treat a patient, when do we need to treat a patient, and of course, which options can we provide our patient with, and how does this lead to a final outcome. And therefore it's a great pleasure to introduce Pierre Grandmont. He's coming from the University of Montreal and enlightening us on what needs to be done and what are the numbers when it comes to posterior dentures sites.
Very good. Thank you, Mr. Chairman. So basically my presentation this morning would try to answer 3 questions. What are the needs? What are the treatment options? And is there any barrier to those treatments? People in developed countries are keeping their teeth more than ever. In fact, in the last 30 years, we have witnessed a drastic change. In Canada, the number of dentures person has decreased by almost 400%. The actual rate is about 6.5%. It is similar to the rate in Australia and the United States. As expected, the most dentures are over 60. However, the individual in this age group shows today a much better oral condition than their predecessors. They were able to go through the last 30 years without changing much their dental condition. The same could be said about those in the middle age. Despite this reduction of tooth loss, it is believed that prosthetic need will still increase and for many years to come. The rationale behind this statement is that people do keep their teeth, but not all of them, and since they live longer, they are likely to lose some more as they get older. So, if people don't keep all their teeth, how many teeth do they have? Canadians have on average 25 teeth. It's about the same number than American. It goes from 27 in the young adults to 19 in the elderly. Those numbers, again, shows an improvement in the oral condition of the North Americans. The demographic data suggests that if you visit a dentist on a regular basis, if you have a good education and a good job, and if you never smoke, you're not likely to be in need of prosthetic treatment. If people don't keep all of their teeth, which teeth are they missing? In 1923, Edward Kennedy came with a simple classification for the partially dentalist. This classification is based on prevalence. According to Kennedy, the class 1 and class 2 pattern of tooth loss are the more frequent. This has been supported by many other studies. In fact, 70% of the partially dentalist patients are missing posterior teeth and are having free end saddle. It is believed that people with a reduced number of posterior teeth could experience a reduction of their masticatory efficiency. They would display tooth movement and tooth wear, the so-called posterior bite collapse, and they could suffer from temporomandibular dysfunction. This is why dentists, in order to prevent those physiologic changes, have been prescribing prosthetic appliances. Filling the gap has been one of the main objectives of dentistry. However, Scandinavians have been questioning this approach. According to Kaiser, it is not necessary to replace every missing tooth, since individuals can adapt and are able to maintain an adequate oral function if they have at least 4 occlusal units in a symmetrical position. Studies have shown that individuals which keep all their premolars and anterior teeth, they don't complain generally about their aesthetic. They do have an adequate masticatory efficiency. They will show some tooth movement and tooth wear, but this tends to stabilize. And despite some slight changes in the TMG, those patients do not suffer more of dysfunction than the fully dentate subject. It is why the World Health Association has adopted as a goal for oral health the retention of not less than 20 teeth without any prosthetic appliance. This concept of shortened dental arch helps us to understand also why so many patients do not seek treatment after they lose some of their posterior teeth. The rationale for tooth replacement is most often aesthetic and social concern. Patients are 13 times more likely to replace anterior than molar, and 4 times more likely to replace premolar. Studies have shown that the loss of molar has less impact on the oral function and general satisfaction than does the loss of anterior and premolar. However, people are likely to change their mind if they lose more teeth. It has been shown that individuals with less than 20 teeth do complain about some functional deficiencies, and they are less satisfied. If we look again to the Canadian statistic, we can see that most of the people in this situation are in the elderly. 40% compared to 16% in the middle age. Those are the ones in need of treatment. However, they are also likely to have a low income and therefore be limited in their capacity to restore their dentition.
When you consider the treatment options, what do you think are the treatment options? If I consider what we have today, how should I make my decision? I mean, I have fixed and removal, I have implant retained, I have obviously no need for treatment. How do you make the decision, or how do I make my decision on Monday morning?
practitioner has to consider while in choosing a treatment for their patient, there's three things you have to consider. The prognosis of treatment based on the longevity. There's local and systemic factor which influence the reported outcome. And of course, the patient needs and preference. Let's start with the longevity of treatment. Everybody agree that today dentistry should be evidence-based. Systematic reviews are useful for clinicians to review quickly the literature and base their clinical decision on evidence. However, there's a problem. The level of evidence in dentistry is improving, but it is still low. Prosthodontics, there is few RCTs. Many studies are short-term, based on a limited number of patients. It is difficult to compare the studies because there is a lot of variation in research protocol. This is why the author of this systematic review stated that it is not possible to come to meaningful conclusion when comparing the different treatment options for the partially dentist. So, we're not left with much with that. I do think there is more to learn about the reported evidence. This table is summarized the work of a group from the University of Bern who did a series of systematic review on the various types of fixed partial denture. I did add some data on the RPD, on removable partial denture, to complete the picture. As we can see, RPDs are no match compared to fixed solution. And when we look to success or survival rate. It's not a surprise to us. Many of you consider removable partial denture as a second type of treatment. We do tell the patient to change them very frequently. So they don't perform as well on the long term. When you compare the fixed option, short-term results are similar, but there's more differences on the long term. This group concluded that the conventional fixed dental prostheses and the implant-supported prostheses could be considered as good option. However, they also stated that the category of fixed bridges and the tooth implant-supported prostheses should not be considered as primary treatment option. Last year, they updated their review, and this time they chose not to include studies with machine surface implant and acrylic veneer prostheses. They were able to show a much bigger difference in favor of implant-supported fixed partial denture. Therefore, this new analysis seems to suggest that implant-supported fixed partial denture are the treatment of choice when long-term prognosis is considered. There is also another way to compare treatment, is to look to the complication. Removable partial denture are at their best the day of their insertion. There is an ongoing process of wear and tear, which would lead to need to repair or replacement of 20% of the partial within 5 years. But mostly, the concern about RPDs is their effect on the oral tissue. According to those two studies, 40 to 60% of the patient will suffer of decay within 5 years, and up to 80 within 10 years. This is maybe a little bit on the higher range of what we find in the literature. However, as stated by Berman in the early 1970s, we have to acknowledge that RVDs could be really detrimental in absence of adequate oral hygiene. Cantilever fixed partial denture don't provide the best biomechanical condition. Because of the forces generated through the pontics, loss of retention, abutment and prosthesis fracture have to be expected. There's also high prevalence of endodontic complication that has been reported. Both technical and biological complication rates are higher than those reported for the conventional fix. Complications associated with implant-supported bridges are mainly technical. They are related to screw issues, to loss of retention for cemented prostheses, to management of access hole for screw retained. There's also a problem of veneer fracture, which has been associated with the type of material that you use. Specifically, I don't think there's nobody that uses acrylic anymore. We had a lot of problems with those. So, although frequent, the complications associated with implant-supported bridge are mostly technical and they don't have much consequences. Tooth implant-supported fixed partial denture also are at risk because of biomechanical consideration. Despite some interesting work, namely the work of Gounet and Aslan, this treatment option is still controversial. Beside the problem of tooth intrusion, which is also associated with the type of attachment that you use, a lot of abutment loss, tooth and implant have been reported. Finally, removable partial denture could also be supported by implanted tooth. That would represent an expensive way to replace missing teeth for patients. This treatment option, however, is not well documented yet. The results are promising, but still sparse. Like conventional removable partial denture, prosthetic complication and need of repair has to be expected, and also the risk of decay would be high in absence of adequate oral hygiene. To complete this quick overview of treatment option, I will say that it would be wise to remember that patients requiring the restoration of their dentition have already demonstrated the susceptibilities to disease, and clinician and patient have to expect complication. This is why we can say that implant-supported prostheses, although associated with some complication, mostly technical and minor, could also again represent the treatment of choice.
If I may interrupt you again, Pierre. Now, if you see, we should go for implant treatment with the patients, as you explained very nicely. Where, and when I go into my own private practice in the past, I mean, many patients were reluctant to use going for implants, and are there underlying barriers that prevent patients maybe from selecting, obviously, the most appropriate treatment in regards not only to initial, but for the long-term maintenance of their oral health?
Okay, so I think that in addition to longevity, to factors that we will review through our examination, we need, of course, to take into consideration the patient preference and expectation. Patients who choose or refuse a treatment do share common characteristics. According to this study, patients express wishes and concerns which strongly correlate to their choice of treatment. If we look to implants for prostheses, it is well known that the fixed nature of this type of treatment is appealing to patients. However, the complexity of the procedure, the risk of complication, and the cost are also major reason why they refuse implant therapy. Japanese, Sweden, and American have shown that about 1/3 of the patients openly admit that cost is the main reason why they don't proceed with implant treatment. We have to remember that today, the patients who have lost their teeth are more likely to be with limited financial resources. Implant therapy and implant rehabilitation could go to up to 30 to 50,000 Canadian dollars. It has been reported that 55% of the adult population of the province of Quebec, the region of Canada where I come from, do report an annual earning of less than $30,000. Also, according to Statistics Canada, Canadians do spend on health care around $1,300 to $1,400 a year. As we can see, this is what they spend not only to dental treatment, but to all the other medical expenses which are not covered by our healthcare system. As we can see, there's not much room in such a budget for comprehensive dental care. I don't think this situation is specific to Canadian, and I even believe that unfortunately it is worse in other regions of the world. When you remove cost as a factor, there is still one-third of patients that will refuse to go through implant therapy. And the main reason for this is fear of surgical risk, fear of complication. Considering the fact that patients do wait a substantial amount of time, or they wait until they lose a substantial number of teeth before they do seek treatment, it is likely that anatomical restriction will be present in the posterior region. And even if we can use short implant or tilted implant to overcome those problems, surgical procedure are often needed and add to the complexity of the treatment. Considering what I just said about patient fears, then we understand again why many of them do refuse that type of treatment. The quality of life is often associated with the loss of teeth. However, we have to acknowledge that the quality of life cannot be assessed by how much money or how many teeth someone has. It is influenced by values and priorities which change throughout life. It has been shown that 50% of the fully dentate subject would consider implant therapy if needed, versus what less than 10% of the dentless patient does. This shows that the perceived need for implant treatment is influenced by the dental status, but indirectly by age. As people get older, they tend to adapt and to cope to chronic conditions such as tooth loss. They tend to accept their condition and its limitation. It is why I believe that practitioners are more likely to provide single tooth restoration to young individuals than fixed partial denture to their senior. I will conclude this overview by saying that missing posterior teeth is frequent, more so in older and underprivileged patients, that treatment is not always needed, and when needed, there's a lack of evidence to support treatment choice. And despite the advantage of implant-supported prosthesis, there's many barriers to that type of treatment. Therefore, I strongly believe that we have to work in order to simplify our procedure, and more so in order to reduce the cost, so that more people would benefit from that type of treatment.
Thank you, Pierre, for this very, very nice introduction. That's really impressive, because now we know why we have these implants. And that was extremely interesting to see the need for treatment, and for instance, the fact that